Cool. Thank you. So discharge reports. Yeah. So this is the final of the priority categories that we tackled in the scope of the Xt EHR. The first thing, actually, the first information that you get on this slide was one of the first obstacles that we faced. Asking ourselves, what is a discharge report? So unlike the previously mentioned priority categories, discharge reports were the ones, I think, with the most diversity among the member states, and even here in the project partners themselves. So the first challenge was building on previous projects, as Sinek also mentioned, to define the discharge report, what it is and what data it contains. Another thing with the discharge report, it's obviously a crucial document that ensures the continuity of care, not only across borders, but also in the national settings, even within the same institution, typically. And of course, obviously, it's one of the EHDS regulation defined categories, priority categories of data, which brings me to the second obstacle that we faced. So the work of the project, as I guess most of you here are aware, actually started before the regulation actually passed in the European Parliament. So we were working on versions that we could get hands on, so the comatology versions and so on. And one of the things that changed for us, especially in this task, was the change from the hospital discharge report to discharge report. So the hospital was left out, actually even further widening the scope of this priority category, and also moving it away from the actual guidelines that we were building our work on, the EHN guidelines and the work in previous projects. Next slide, please. So, as I said, with the removal of the hospital part of the hospital discharge report, we were left with a discharge report, meaning that not only hospital discharges, but also outpatient care episodes, emergency care, long-term care rehabilitation were all included in scope, which was again a challenge, not only because there were differences in the data elements that these diverse documents typically include, but also in terms of what each of the member states' legislations say about these documents, even in many cases not having to say anything because these documents are not part of the nationally prescribed clinical documents, or at least not in that scope. So the first few months we were basically working around the concept of the discharge report and what it means for the member states and the project partners. Of course, similar to other priority categories, other tasks, we were considering this both on the national and regional exchange levels, but also on the cross-border exchange level, of course, having the My Health at EU future services in mind. And yeah, similar to other priority categories, the main purpose was, again, the continuity of care, the support for clinical decision making, which for this priority category is especially important, and providing the patient access to their clinical documents, especially when they're moving from institution to institution, as this is typically the case and the purpose of a hospital discharge report. So to be able to continue the care and treatment of the patient. Next slide, please. Yeah, so with the hospital discharge report, one of the crucial things and one of the specificities of this priority category is that it has quite a long life cycle, meaning that the hospital discharge report or discharge report needs to be able to capture everything that goes on with the patient from the point in time when they are admitted to a treatment facility, say a hospital, until the end of that treatment episode. It has to follow up everything that went on with the patient and be able to provide to end with a report that can be taken onward to continue care for that patient. Having said that, one of the things that we started off doing when we began with the task and we began with the drafting of the deliverable, and actually began with trying to map out the data model for the discharge report, was to go with this kind of like a full detailed approach, meaning that we wanted to capture everything that would go on with the patient in the course of a, again, say hospital treatment or any kind of treatment that ends up with a discharge report. And we spent the first, I would say, 6 or more months on that effort. At some point in the other half of the project, we quickly understood that this will probably be a never-ending task if we just keep on adding specific data elements and specific modules, like specific specializations to the data model in the discharge report. And we actually ended up with the light version of the discharge report, which basically only includes the discharge report itself. So just the final information that the patient would get at the end of the treatment episode. Of course, reusing different models similar to other product categories, such as medications, which are relevant for that discharge. Yeah, the actors that are used were aligned with other priority categories, with other tasks, and also are in line, or were in line with Work Package 8 and Work Package 5. All the standards that you might expect are being used. So this is the same for as with the other priority categories. Maybe not so obvious is that we had, due to the sheer complexity of the discharge report and many different elements it does contain, I think we have the highest number of used terminologies and different standards that are being used and reused and referenced in our models and in our final deliverable. Next slide, please. So the biggest challenges for us were, including the ones that I mentioned before, the definition of the report, the discharge report, the lack of clarity due to the late passing of the regulation in the parliament, then trying to include every single data element that we could think of in the discharge report, and then moving to a more light model. The biggest challenge towards the end was actually making sure that the final version of the logical model and the resulting implementation guide, as well as everything else that we put into the deliverable, actually fits the member states' infrastructures. Having in mind, again, that the discharge report is probably the most diverse document that you can think of in the scope of the regulation. So many different ways that the countries can and organizations think of when they hear the discharge report. Similar to what my other colleagues said, there's a lot of work still to be done for discharge reports. Specifically, this is again the fact that we removed in the final version. We removed much of the content, so it's strapped the model to kind of the bare minimum. The reason for this, again, was that we wanted to end up with something that is as easily implementable as possible across the member states, so not overburdening the member states and the healthcare organizations too much. However, we did map out a lot of things that were, again, left out, and these things would probably there's clinical need to to implement these things as well. So the regulation and the standardization under the regulation is one thing, but the actual clinical practice and the actual clinical need is something else. So similar to other tasks, this work will probably need to go on. It will go on, it will live in some shape and form through the My Health TU project, if you will, but and of course the other communities, HL7, IHE, that will keep track of things, but still there are many experts that were involved in this project that I would like to kind of stay in close contact with and continue working on further refining the discharge report. I think this is the last slide from my part. Thank you. Thank you, Andreas.